Mabuhay! Welcome to Class 1999's webinar series. Maraming salamat po sa inyong pagdalo. We would also like to thank Class 98 for allowing us to start implementing our homecoming activities 1 year before our Silver Jubilee year in 2024. I hope you will learn a lot from our webinar series and participate in the succeeding events that Class 99 will sponsor leading up to our homecoming in December 2024. Mabuhay po tayong lahat!
In a world that is perpetually changing, there is increasing need for steady leadership. Companies demonstrating the courage to address the world's emerging healthcare challenges with passion and compassion. Viatris is redefining the healthcare landscape. We are uniquely positioned to be a source of stability with the commitment, capability, and vision to meet the world's evolving patient needs. Viatris believes in healthcare not as it is, but as it should be. We know the way to provide access to a sustainable, affordable, and diverse portfolio of high-quality medicines, regardless of a patient's geography or circumstance. We are leading the way by providing a versatile, scalable platform that combines best-in-class manufacturing and supply capabilities with innovative solutions that span therapeutic areas. And as a partner of choice, we are pioneering a way to empower companies of any size to leverage our distinctive global healthcare gateway, so products from across the industry and around the world can rapidly and effectively reach patients where they live. We do so with a collective spirit of resilience, driving forward until each challenge is addressed and every opportunity embraced. We are inspired by this moment of shared purpose, because as Viatris, we know the way to empower people worldwide to live healthier at every stage of life.
Mabuhay! Welcome to Class 1999's webinar series. Maraming salamat po sa inyong pagdalo. We would also like to thank Class 98 for allowing us to start implementing our homecoming activities 1 year before our Silver Jubilee year in 2024. I hope you will learn a lot from our webinar series and participate in the succeeding events that Class 99 will sponsor leading up to our homecoming in December 2024. Mabuhay po tayong lahat.
As we gather for this webinar, which is part of the UPCM Class of 1999 webinar series, let us acknowledge the source of all wisdom and the creator of life. In the name of the Father, and of the Son, and of the Holy Spirit, amen. Our Father, we come to you grateful for this opportunity to expand our knowledge of the many wonders that you have imbued in the human body. Grant us knowledge and understanding so that we may better use our intelligence to bring healing and comfort to our brothers and sisters who are ill. Grant us humility to treat our patients with compassion and love. We pray also for our presenters. May they share with us their expertise with confidence and kindness. We ask all this through your Son, the Divine Physician, Jesus Christ our Lord. Amen. Sa ngalan ng Ama at ng Anak at ng Espiritu Santo. Amen.
We would like to ask everyone to kindly turn off your microphone and video. Please type your questions in the Q&A chat box. We will try to address all of them in the open forum after the presentation. Evaluation and post-test questions will be available for 1 hour after the initial broadcast. A certificate of attendance will be emailed to you once the evaluation and post-test are completed.
Good afternoon, everyone. I am Dr. Mark Allen M. Lopez of the University of the Philippines College of Medicine, class of 1999. I am an orthopedic surgeon and a fellow of the Philippine Orthopedic Association. My subspecialty is joint replacement, reconstruction, and revision, which are procedures that are most commonly performed for patients who suffer from the disease that is our topic for today. I am here on behalf of the UP Med Webinars team of the class of 1999 to moderate today's webinar. Our topic today is about the early diagnosis and treatment of osteoarthritis. Before we introduce the speaker, we would like to remind the audience that you can type your questions in the chat box even while the lecture is still ongoing. For today's webinar, we are privileged to have a distinguished alumnus of the UPPGH Rheumatology Fellowship Training Program. Dr. Auxencio Lawrence A. Lucero Jr. had his residency training in internal medicine at the San Juan de Dios Hospital. He took his fellowship in rheumatology at the University of the Philippines Philippine General Hospital. He is presently the chair of the Department of Internal Medicine at the San Juan de Dios Hospital and is the vice president of the Philippine Rheumatology Association. Ladies and gentlemen, we are proud and honored to welcome Dr. Auxencio Lawrence A. Lucero Jr.
Hey, good afternoon, everyone. Let me just share with you my slides for today. So can you see the slides?
Yes, sir, it's visible.
Okay, so good afternoon, everyone. First off, before I begin, I'd like to take this opportunity to thank UPMAS, particularly class of 1999, for inviting me once again to be a part of this webinar series. And as a matter of disclosure, I also would like to thank Viatris for sponsoring this talk for today. So the title of my topic is OA pain, early diagnosis and treatment. So just a disclaimer, everything that you will hear for today, all informations are mine, and they are purely for educational purposes only. So these are my disclosures. So this is my goal for today. I will be describing to you the burden of disease, the clinical manifestations, the risk factors, and the differential diagnosis associated with osteoarthritis, and then segue into discussing treatment, particularly medical treatment, and this emerging concept called the early OA concept. So this will be the flow of my talk. So let's begin with the burden of disease. So OA is the most common arthritic condition worldwide. In the most recent data coming from the Global Burden of Disease study, the prevalence of symptomatic OA is presently placed at 7.6%. So this translates to about almost 600 million people worldwide, predominantly in female, and the most common joints involved are the knees, hands, and hips. Now, since 1990, if you look at the table below, there's been at least 130% increase in the total number of cases and in the contribution to disability for osteoarthritis. So worldwide, OA is placed or ranked 14th for contribution to disability, but among the elderly population 70 years old and above, it's within the top 10. And among the different types of osteoarthritis, it is knee osteoarthritis that contributes significantly to this disability. Now, at the same time, the quality of life of patients with osteoarthritis are also affected. So there's this systematic review that looked at the data from 62 studies, numbering about almost 25,000 patients diagnosed to have knee osteoarthritis, and they measure the quality of life of these patients versus those without this condition. And the different studies actually made use of different instruments, such as those listed here. And the result shows that whatever instrument was used to measure the quality of life, it was always worse in patients with knee osteoarthritis. And poor outcomes were related to gender, weight, level of physical activity, financial status, mental health status, and the level of familial support. And those who reported positive outcomes, they were enrolled to self-management programs and had higher educational levels and total mindfulness. Another thing to consider in patients with OA is the presence of comorbidity. So there's this systematic review and meta-analysis that looked at the prevalence of comorbidities in patients with OA. They looked at 42 studies, including about 1.6 million patients with osteoarthritis. And based on this study, the overall prevalence of comorbidities, meaning at least one comorbidity, was placed or estimated at 67%. So 29% reported at least one, 25% reported two comorbidities, and 24% reported at least three comorbidities. And the most common comorbidities are stroke, peptic ulcer disease, and metabolic syndrome. Now, we do have our own data in the Philippines. In the most recent prevalence data coming from the National Nutrition and Health Survey way back in 2003, osteoarthritis is just the third most common arthritic condition behind gout and rheumatoid arthritis here in the Philippines. But this is in contrast with two studies done by Cupcord in 1991 for a rural setting and in 1997 for an urban setting. And these two studies clearly shows that OA is the most common arthritic condition in the Philippines. Now, the differences in the outcome might probably be due to the differences in the methodology adopted in each of the studies. However, what is apparent in the data is that even among Filipinos, consistent with worldwide data, there's increasing prevalence with age. It's more common in the middle age, the elderly population. And among Filipinos, consistent with worldwide data, we have common occurrence on the knees, hands, but instead of the hips, more common in the Filipinos would be the involvement of spines. Seldom do we see the involvement of hips, ankles, and shoulders. Now, OA is expected to grow in the coming decades. And in fact, by 2050, it is projected that about 1.1 billion Filipinos, people worldwide, will have at least some form of osteoarthritis. And this is consistent with the growth in the elderly population. And this is also true in the growth of the elderly population in the Philippines. Now, according to the WHO data, the obesity pandemic has also increased in the last 1.5 decade from year 2000 to 2016. From 8.3%, it has grown to 13.2% in 2016. So given this global burden of OA, it now becomes imperative for us doctors to diagnose or even see these patients as early as possible and manage them accordingly to prevent long-term disability. So what do we now know about this condition? So I will not be sharing with you underlying molecular changes in OA, but rather share with you what we now know about this condition. So it's a misnomer to simply regard OA as a simple wear and tear disease. The present paradigm that we are following now is that it is actually a failure of the synovial joint as an organ. And so while the hallmark still remains as the articular degeneration, the other important tissues such as the synovium, the subchondral bone, and all the periarticular tissues surrounding the synovial joint are also affected. And we now know that it is actually an interplay of several factors. So for example, patient profiles such as the age, the weight, the heritability factor will interact with underlying comorbidities on the patients, and then a trigger will start the process. So the usual trigger would be your trauma or repetitive joint use, and this starts an inflammatory cascade that tilts towards the catabolic event. So what you have overall would be something like a smoldering disease that is slowly progressive through the years. So how do they present to us? So the most common reason why they come to us for consult is because of joint pain. So in patients with OA, they usually complain of chronic pain. Okay. But according to this model of diminishing reserve, this is how actually OA behaves. So there is an acute flare or an acute pain on top of the chronic pain. So in the beginning, when the organ reserve is still very much intact or close to normal, flares would occur few and far between. And if it occurs, it's usually of short duration. And then when the organ reserve starts to diminish, then pain becomes more frequent and longer duration until such a time that it breaches a critical threshold, which is still unknown at this time, and pain becomes more constant in the patient. Now, if you ask the history of the patient, they will share with you that the joint pain is actually aggravated with prolonged use, and it is relieved by rest, and it is associated with stiffness either in the morning or after inactivity, but it doesn't last beyond 30 minutes. And if you ask for the source of the pain, if it's articular, then they will describe it as coming from deep within the joint, or the entire joint is actually affected. But if your patient is able to localize where the pain is coming from, then you might be dealing with a non-articular source of pain. Now, for risk factors, I've already alluded to age and obesity. So as I've said, age is more common to the middle-aged and elderly population. Seldom do we see it in patients below 40 years old, and it's more common in patients 60 years old and above. For obesity, we're looking at two mechanisms here. One would be the biomechanical effect of the weight on the weight-bearing joints. And for the non-weight-bearing joints, we're looking at, based on research, the contribution of adipokines. Okay. Now, other risk factors, it's more common among females. There's some sort of heritability, but it is very joint specific. Anatomic factors such as joint incongruence or malalignment can lead to this condition. Exposure to heavy manual labor or occupation requiring repetitive joint use can also increase risk. And those who have had a history of major injuries also increases risk for this condition. Now, for musculoskeletal physical examination, it's a little bit different from the way we do it from the other organs. For musculoskeletal condition, there's still role for inspection and palpation, but percussion is replaced by examination of the range of movement. And for auscultation, it is replaced with special maneuvers, an example of which would be something like a Tinel's test or a Fallon's test if you're considering carpal tunnel syndrome. So to simplify, PE of the musculoskeletal organ would be this mnemonic: look, feel, and move. Okay. So look would be equivalent to the inspection. So as soon as the patient comes into your clinic, might as well observe the way they walk, and then as soon as they are comfortable and already exposing the involved part, then check for swelling, deformity, wasting, attitude, and the skin. For the attitude here does not refer to the demeanor of the patient, but rather how the patient places the joint to lessen the pain on the involved joint. So this is just an example of what you can see in your patient. So this is a bony hypertrophy of the DIP and the PIP. So if you see it in the DIP, we call this Heberden's nodes. If you see it on the PIP, then we call this the Bouchard's nodes. And then also try to inspect whether there is bow-leggedness or knock-kneed appearance. And I don't know if this is clear with you on the picture, but if you compare the thigh muscles of the right thigh to that of the left thigh, then you will see a little bit of wasting on the right thigh. And then for the skin, look for signs of inflammation like erythema, aside from rashes. And then for the feel, this is equivalent to the palpation. Feel for tenderness, swelling, crepitation, and temperature. So, for example, if you're examining the knee, you can place one hand over the knee while moving the joint and feel for the crepitation, which is a grating sensation. And then for the temperature, just a suggestion, studies are telling us, or rather the books are telling us, that the dorsum of the hand is actually more sensitive than the palmar aspect of the hand. So this is more sensitive to changes in temperature when examining the changes in temperature in the joint. Okay. And then for movement, try to differentiate the response between active and passive movement. So active is when the patient is the one doing the movement on the involved joint, and passive is when the doctor is the one doing the movement. So if there is limitation of movement on both active and passive movement, then most likely you're dealing with an articular source of pain. But if it's only on active movement, but not on passive, then you're dealing most likely with a non-articular source of pain. And then for resistance, if you elicit pain on specific movement or position, then most likely you're dealing with a non-articular source of pain. So how do we diagnose OA? So in 2009, the European League Against Rheumatism actually published a diagnostic criteria. A lot of the criteria out there is mainly classification criteria. So it's mainly used for research purposes. But this one, we can actually apply to our patients individually in the clinic because it is a diagnostic criteria. So they listed here symptoms and signs for knee and hand. And if you have most or all of these symptoms, then most likely your diagnosis of an osteoarthritis is correct. So just to show you what they mean in the study, if you have at least or all of the three symptoms and all of the three signs in your patients, then the probability of a correct diagnosis increases to 99%, especially if you were able to elicit these risk factors in your history. Now, if you notice, in this diagnostic criteria, you don't need blood test or x-ray to be able to make a diagnosis of OA. So diagnosis is mainly clinical. And then, but if you need to do an x-ray, these are your common findings. So just to show you a picture, you can see presence of osteophytes here, subchondral sclerosis, the whitish part, joint space narrowing, and the presence of subchondral cyst. And the only time probably you need to request for an x-ray would be one, if you're entertaining a different diagnosis, two, if your patient remains symptomatic despite medical treatment, and third, if you have an atypical presentation. So what are the common differential diagnosis of your patients with OA? So let me just walk you through this algorithm here. So we need to differentiate whether this is articular or non-articular. So if you answer yes to both of these questions, then most likely you're dealing with an articular source of pain. Now, you need to differentiate whether you're dealing with an inflammatory type or a non-inflammatory type of arthritis. If you answer yes to all of these, then you're dealing with an inflammatory source or inflammatory type of arthritis, and this would be your differential diagnosis. But if you answer no to all of them, then you're dealing with a non-inflammatory type of arthritis. Now, OA is typically non-inflammatory, and it involves the weight-bearing joints and the hand joints, particularly the PIP, DIP, and the first carpometacarpal joint. So if you go to this side and you're most likely dealing with a non-inflammatory type of arthritis, then OA would be the correct diagnosis for these patients. But as I have shown you in that model of diminishing reserve, you might have instances where you have flare, and then you go to this side and a differential would be your OA with inflammatory flare. Now, RA is a differential diagnosis. Probably what you have in mind is a patient already presenting with polyarthritis, which is symmetrical in presentation. But in the early course of RA, there might be presentation of a mono or oligoarticular with inflammation. And the only way to differentiate it with OA with inflammatory flare would be testing for serologic markers like rheumatoid factor and anti-CCP. Now, another would be gout. Gout typically presents as monoarticular, but the level of pain compared to patients with OA would be more severe. And if you do testing for gout, you will appreciate an elevated uric acid, and definite diagnosis requires detection of the monosodium urate crystal. And then lastly, you have to think of septic arthritis, particularly in patients presenting as monoarthritis with underlying risk factors like age, immunocompromised patients with a history of pre-existing joint disease like OA, RA, and has had history of joint replacement. So the only way to differentiate this with a non-infectious type of arthritis would be culture, either from the synovial fluid or from the blood. And if you do synovial fluid analysis, if you have more than 50,000 cells per cubic millimeter, then you cannot rule out this particular condition. Okay, so how do we treat patients with osteoarthritis? So the main goals of treatment are to alleviate pain, improve function as much as possible, and to delay the progression as much as possible. And treatment ranges from non-pharmacologic to surgical management. But for this particular talk, I will just be concentrating on the medical treatment. Okay, so recently, this was just published a few months back. there was a systematic review of all CPG guidelines that was published from 2015 to 2022. And then they collated all the recommendations from these CPGs and made a generalized recommendation. So they were able to identify 20 CPGs. 11 of them were appraised to be of high quality. And then they made a recommendation based on this classification. It should be applied to all patients based on strong evidence. Could do, you can still recommend this, but it depends on the patient's circumstances. Do not do, this has been shown to be of no benefit to the patient. And the gray area where some CPGs recommend them and the others do not, because of incomplete or inconsistent evidence for these modalities. So let's go through each one of them. So for the should do, these are your main non-pharmacologic measures that should always be emphasized to your patient. For pharmacologic, they only recommended NSAIDs, whether oral or topical. And for surgery, if your patients remain symptomatic despite non-pharmacologic and pharmacologic management, then we can refer them to our orthopedic colleagues for surgical management. So let's go through each one of these should do recommendation. So the main core of treatment for OA is the non-pharmacologic treatment, and these three should always be emphasized: education, exercise, and weight loss. For education, in Western countries, they have what we call self-management programs. These are formal classes. Patients are taught what the condition is and also taught what they can do to manage their condition. In the Philippines, we do not have them. What we have is the standard clinic encounter that we do. And according to the Philippine Rheumatology Association, the standard clinic encounter is equivalent to the self-management programs in Western countries. For exercise, it's mostly land-based, incorporating these types of exercises. But according to them, there is no consensus on what the best type of exercise, but they recommend individualizing it depending on the patient's circumstances. And for weight loss, the minimum would be at least 5%, particularly in patients who are overweight or obese. So this study is actually not part of the Conley et al. Systematic review, but I just wanted to insert it here because this is a more recent findings, just emphasizing the value of weight loss in patients with OA. So this data is coming from this longitudinal cohort study called the OA Initiative. They looked at around 3,000 patients diagnosed to have osteoarthritis. And then they wanted to see whether there is a relationship between significant weight change versus no significant weight change in terms of joint space narrowing and symptoms such as joint pains. So the result shows that in patient who has had significant weight loss, weight gain, the odds ratio of joint space narrowing and joint pain actually increased by 29% and 34% respectively. In contrast, those who have had significant weight loss, the decrease in joint space narrowing and joint pain resulted to about 31% and 40% respectively. Curiously though, for all hip outcomes, there was no significant associations found. Okay. So back to the systematic review by Conley et al. They also recommend patient-centered care, meaning whatever we do to our patient, there should be a shared decision-making and should be individualized according to their circumstances. And for those who have hand osteoarthritis, hand orthosis can be recommended. Okay. For NSAIDs, you can use either oral or topical. If you're going to use oral NSAIDs, make sure to use the lowest effective dose at the shortest time possible, but be mindful of these side effects. For those patients who are in the elderly population, particularly more than 75 years old and with significant comorbidities, a topical NSAID might be more appropriate to these subsets of patients. Now, for surgery, as I've said, if everything else fails, then we can refer them to our orthopedic colleagues. Now, for could do, we can still recommend these non-pharmacologic and pharmacologic measures depending on the patient's situation. If you're only dealing with one or two joints with pain and inflammation, then intraarticular steroid injection done either manually or through ultrasound guidance can be recommended. If there is already pain sensitization or depression in your patient, then duloxetine can be recommended. These two modalities actually do not have a direct impact on OA, but rather have an impact on surgical complications. So these are not recommended in patients with osteoarthritis. So for colchicine, they do not have a role unless there is a concomitant underlying crystal-induced arthritis like gout or pseudogout in your patients. And the combination of glucosamine and chondroitin is not recommended for patients with hip and polyarticular OA, but there probably is a role when giving this individually to your patients, which I will go through in detail later on. For the no consensus, these are the gray areas. So some of the CPGs recommend them, some of the CPGs do not. So you can still recommend these to your patients based on the shared decision-making process. Now, I just would like to highlight two important pharmacologic measures here: paracetamol and nutraceuticals, and I will be discussing them why. Okay, so not part of the systematic review by Conley et al. Are two CPGs. One would be the Philippine Rheumatology Guideline published in 2008, and the other would be the Southeast Asian Working Group Guideline, which was published in 2021. Okay, now the Southeast Asian is also important for us rheumatologists because there were 4 Filipino rheumatologists who took part in drafting this guideline. The 2019 ESEO guideline was actually included in the Conley et al. And was appraised to be of low quality. However, as I will show you in the succeeding slide, it is actually more in sync with the PRA and the Southeast Asian Working Group. So if you look at paracetamol and glucosamine, they actually recommend these two treatment modalities as an alternative analgesic for patients with knee osteoarthritis. Okay. At the same time, in the study by Dr. Zamora et al. Published way back in 2012, while NSAIDs remain the most prescribed drug for the management of pain in osteoarthritis, a significant number of doctors also prescribe glucosamine sulfate and paracetamol. Hence, the need to review the data here. Okay, so let's begin with paracetamol. So this used to be the traditional first line, but more recent meta-analysis have shown that it might be minimally effective in relieving pain and improving functions in patients with knee osteoarthritis. And given at higher doses, more than 3 grams per day, also shows a lot of adverse events for these patients. So let us review the evidence for paracetamol. I'm just going to show you 3 important meta-analyses here, published in different years. So they have varying numbers of RCTs. So it follows that they have different number of participants depending on the included or the inclusion criteria. But what is more important here is they defined the MCID, or the minimum clinically important difference. So according to all of these meta-analysis, paracetamol was statistically significant versus the placebo, but not clinically significant. But this is based on the mean of the paracetamol treatment. But if you, I did not show it here anymore, but looking at the data, particularly the range of effect of the effect size of paracetamol, it actually breaches a lot of these MCID that was defined in the meta-analysis. And so what this tells me is that in a lot of patients, it may not work, but in a significant proportion of patients, it may also work. And therefore, this remains a viable alternative to our patient. And in fact, in the Banuro et al. Meta-analysis, when a head-to-head comparison was made between celecoxib and paracetamol, there was in fact no difference between the two. And in terms of safety in this Leopoldino et al. Meta-analysis, in terms of adverse event, there was actually no difference between paracetamol and placebo. So the recommendation of the three guidelines here is that paracetamol used at a lower dose of 3 grams or lower still remains a viable option for our patients with osteoarthritis. Now, how about nutraceuticals? There are several nutraceuticals available in the Philippines: the glucosamine, chondroitin, and the avocado and soy oil and saponifiable. So much debate has been done on glucosamine because there are actually two preparations in the market: the hydrochloride salt and the sulfate salt. So let's try to analyze the data on this one. So way back in 2014, a meta-analysis was done, which included 25 trials. They compared the effect of the sulfate salt versus the hydrochloride salt in patients with osteoarthritis and then compare this with placebo. They look primarily on change in pain, and the different studies actually made use of different instruments to measure the pain. And the result shows that in patients who were given the sulfate salt, so glucosamine sulfate, there was actually a significant improvement, so on this side, compared to those who were given placebo. Okay, you may be interested, why is this Rotafarm? Because the original maker of the patented crystalline glucosamine sulfate is Rotafarm. And so this was the heading shown here. Okay. Now, compared to those who were given the hydrochloride, if you look at the small diamond here, it shows that there was no difference between those given this hydrochloride salt and that of the placebo. But overall, the study shows a favorable effect of glucosamine driven by the data coming from the glucosamine sulfate. So the overall effect size is moderate for glucosamine, but they wanted to analyze it further because the heterogeneity for this meta-analysis was significant. And so they did a sensitivity analysis, including only those studies of high quality. And they identified 3, and based on the sensitivity analysis of these 3 studies, the effect still shows significant improvement in those given glucosamine sulfate. However, they did not show the data on this one. So the following year, there was another publication done by Bruyere et al., which showed the 3 studies that were included by Register et al., Pavelka et al., and Herrero et al., which clearly shows that whatever instrument was used, the pooled effect on improvement on pain and function was always significant in those given glucosamine sulfate. And the heterogeneity was actually lost in this particular study. And the effect is not because of the brand, but rather the pharmacologic effect of the drug itself. So in a study by Kushars et al., those who were given the patented crystalline glucosamine sulfate at the recommended dose always shows a higher Cmax and a longer half-life compared to those who were given the hydrochloride salt, whether in single dose or in 3 divided doses. So there is a pharmacologic basis for the effect. And so the recommendation is that for patients with osteoarthritis, you can prescribe the patented crystalline glucosamine sulfate. There's also a weak recommendation for the prescription grade chondroitin sulfate in patients who have hand osteoarthritis, and the avocado and soy oil and saponifiable for those with knee osteoarthritis. And then just the last segment of my talk for today. So I Earlier, I shared with you that there's this emerging concept called early OA. So let me just define two terms for us to be able to understand this concept. So disease versus illness. So disease is defined as the abnormality of structure and function, and illness is defined as the way we respond to this disease. So if we put this in the context of OA, disease would be your joint space narrowing and the limitation of movement, and illness would be the joint pains. Now, a lot of times when we see patients in the clinic, they already have both disease and illness. However, research is telling us that in the early phases of this condition, disease may occur without the illness. So in this particular case, early osteoarthritis is actually the asymptomatic disease state. So let me just focus your attention to this diagram. So we now know that osteoarthritis begins many years or even decades as a molecular abnormality before they present as an illness or as an abnormality. So if we accept this, then it now makes sense that you may have patients presenting to you, let's say, of knee pain. So they have the illness, but if you do the x-ray, they don't have anything yet. So this patient may or may not have an osteoarthritis. Or you may get a referral from a colleague, for example, because of a radiographic finding of osteoarthritis of the knees. But if you ask the patient, there's no pain and there's no limitation of movement. And this is what actually the early OA wants us to detect, the early manifestation of the condition. Because if we catch them early on, this might be our window of opportunity where we can intervene much earlier on these patients and affect the course of the condition of the patient. And if we accept this concept, then we can now look at OA as a continuum. So as I have said, most of the patients that we see in the clinic are already here. They already have a well-established condition, and the best that we can do is to prevent the condition from progressing toward end-stage disease, where the best management that we can do is surgical. However, what we want would be to catch them in the earlier stage or even at the earliest stage where management will vary and try to prevent them from further progressing to end-stage OA. So that wraps up my talk for today. So let me just summarize what I discussed for today. So OA will remain a public health issue in the coming years because of the continuing population growth worldwide, the aging phenomenon, and the obesity pandemic. OA is not a simple wear and tear disease. It is now seen as a failure of the synovial joint as an organ. Diagnosis is mainly clinical. The best management that we have at the moment is mainly palliative, but the early OA concept and all the research that goes into this is telling us that this might be our window of opportunity to provide better treatment outcomes for our patient. So with that, thank you for listening and good day. So just a reminder from the sponsors that they have this drug, Celebrex, for OA pain, and this patented crystalline glucosamine sulfate, Viartril S. So thank you.
Well, thank you. Sorry, I don't have audio. Thank you, Dr. Lucero. Right. Thank you, Dr. Lucero, for that very comprehensive and very informative talk. The floor is now open for questions from the audience. Please type in your questions in the Q&A box in the lower edge of the Zoom screen or in the comments section for viewers of the Facebook Live and the UP Manila live stream. There's actually been a few questions that have come in during the lecture. So I suppose I'll try to, summarize them as best as I can. Dr. Lucero, someone is asking, is there a drug of choice for osteoarthritis in the elderly? Like, you have a patient who comes in with osteoarthritis, she's old. What would you recommend as a treatment strategy?
Okay, for the elderly, I think this was discussed in the lecture. You
Mhm.
can start with a topical NSAID. There are several forms. You have the gel type and you have the patch type. So if your patient responds well to this, then and there are no contraindication, then you can use a topical NSAID. You can also use oral NSAIDs if there are no um, contraindication for this one.
Contraindications, yes. Right. Is there a role for nutritional deficiency in the elderly in the pathogenesis of osteoarthritis at all?
Uh, Role for nutritional deficiency. Uh, Probably the answer for this one is no. But
Yeah,
if
same.
patients remain weak, then that can affect for example, the muscles and the improvement of the patient. So they still have to have good nutrition for these patients.
All right, thanks for that, doctor. There's another question here. Could glucosamine sulfate be taken indefinitely? Like, is there a limit, sir? Like, can you just keep taking it?
The longest study, as far as I know, is about 3 years, done, I think, by
Mhm.
Register et al., and it did not show any side effect. So for a lot of my patients, actually, I maintain them on glucosamine sulfate, and in
Right,
my own
right.
personal experience, they are safe to the patient. So if it
Okay.
works, then you can use it indefinitely. If it doesn't work, then
Yeah,
probably we need to
agree.
refer them to our orthopedic colleagues already.
Oh, right. Let's see. I actually have one of my own, sir, if you don't mind. Because in my practice, I frequently give intra-articular steroid injections to my patients, no, for osteoarthritis flares, and most commonly in the knee, which is consistent with your lecture. My question is, if a patient is currently on oral corticosteroids for any reason, can that patient receive an intra-articular steroid injection as well, or do we have to have some kind of drug holiday first before giving the intra-articular steroid?
Okay, so if the patient is already on steroid and your patient is still symptomatic or
Yes, sir.
there's inflammation of the involved joint, then probably you can look at the level of the steroids. If it's a low dose, then probably that is not enough to control the inflammation. Then there's still role for an intra-articular steroid for this patient.
Right. So you don't necessarily have to stop it. Like the oral steroids, you don't have to stop it. Okay, I'm gonna give you an injection. Can you stop the steroid first? You don't need that.
Uh, the Because you have to look at the reason for the oral
Mhm.
steroids. It's
Right.
for if it's for a systemic, for management of a systemic
Yeah.
condition, then there's no need to stop it. But
Right.
you can give it intra-articularly. The exposure of the patient when given intra-articularly would be lower for the
Then
systemic manifestation or
versus
level
oral.
coming from the intra-articular source of the
Right.
steroid.
Okay. Let's try to read through these questions. Wow. Uh, we- there's a question of how does one differentiate between osteoarthritis and rheumatoid arthritis as either as a treating physician or a layman. I'm not sure if it's actually part of the scope of our talk today.
Uh, I guess it can be a part of because I mentioned it as part of a differential
Mhm,
diagnosis in
mhm.
patients presenting with OA. For a clear-cut manifestation of OA, the history and physical examination, you will through history and physical examination, you will be able to differentiate them. So for RA, morning stiffness lasts beyond 30 minutes. Okay, and usually movement improves the involved joints. And this is in contrast with OA, where movement actually aggravates pain. And
Worsens,
then
yeah.
if you do blood test, serologic markers will be able to differentiate OA versus RA. So if your patient has positive rheumatoid factor or anti-CCP, then you're dealing with rheumatoid arthritis rather than osteoarthritis.
Right. Okay, question. All right. Yes. There's a lot of there's a question about is the use of topical NSAIDs safer for long-term use, I suppose, versus oral
Yes,
NSAIDs, sir?
yes. Yes,
Right.
the answer to that is yes,
Mm-hmm.
because the systemic level coming from
Mm-hmm.
the a topical NSAID would be much lower compared to an oral NSAID.
All right. Another question. Because we do recommend exercise for the treatment of OA, but is it possible to overdo it? Like, are there limits to the type of exercise that patients should do?
Okay, so based on the recommendation, you can do strengthening exercises. Tai Chi is also part of the recommendation. If it's available, you can also do water-based exercises. Um, you need to see the level of the fitness of the patient to be able to recommend what type of exercise would fit them for their condition. So
So,
probably if you're not sure what type of exercise that you can give, then you can refer them also to our rehab colleagues, for
right.
management of the non-pharmacologic exercises.
There's a question here. Is there any restrictions on the use of steroid injection for osteoarthritis treatment, sir? As far as you know.
Uh, we don't give it often. The indication would be one if there is inflammation in your patients with OA. If we inject it, we usually tell them that the next injection might probably come in 3 to 6 months. Okay. So you need to space it also because there are also some concern with giving intraarticular steroid injections.
Uh, okay, so I think we have time for just one more question. Uh, where is it? Okay. Um, Regarding calcium supplementation, uh, will it help in a 50-year-old patient with degenerative, I guess, osteoarthritis, and who frequently suffers from fractures? So, I guess, sir, in a sense, the patient is not yet a senior citizen, or traditionally, the age group that you would expect, um, issues to come. Is there a role for calcium supplementation in the 50 somethings, the not quite seniors?
Okay. For osteoarthritis, there actually no role for calcium for the management of symptomatic
Agreed.
OA. However, if you are diagnosed to have osteoporosis or
Right.
you are at risk for developing osteoporosis, then calcium is indicated with you. Okay, so the osteoporosis refers to the thinning of the bone, while the osteoarthritis refers to a problem to the joint itself.
Okay. All right. And I think that's all the time we have for the questions. No? We're terribly sorry for all the questions we were not able to accommodate due to the time constraints. No? Thank you for all your questions, and thank you, Dr. Lucero, for your insights and your answers. To quickly summarize, what we've learned today. Osteoarthritis is still as challenging as ever. It's one of the oldest diseases we've known about, and yet we're still struggling to treat it. Today's lecture has emphasized the concept of osteoarthritis as a disease continuum, with appropriate and recommended treatment and management principles at each stage, particularly in the early stage when we can probably make the most impact for our patients. No? So moving forward, we need to keep these in mind if we are to provide the care that our patients will require. Okay. Thank you again to Dr. Lucero for taking time out of his busy schedule and sharing his expertise with us today. As a sign of our gratitude, we would like to present this certificate of appreciation to Dr. Oxencio Lawrence A. Lucero Jr. Thank you very much, Dr. Lucero.
Thank you also.
We would also like to thank the UP College of Medicine, the Postgraduate Institute of Medicine, the UP Medical Alumni Society, and the UP Manila Information Management Service for their support of this webinar series. And again, thank you to our sponsor, Beatrice. Similarly, we are inviting everyone to watch our next webinar, which is scheduled on November 30, Thursday at 12 to 1 p.m., same time, entitled Keeping Them on Track, Understanding Patient Adherence in Obesity Management. Our speaker will be Dr. Mia C. Fojas. Dr. Fojas is an honorary secretary of the Asia-Oceania Association for the Study of Obesity, and she's also a past president of the Philippine Association for the Study of Overweight and Obesity. So for those who want to get a certificate of attendance, kindly answer the evaluation form and post-test within the next hour. You can access the link through the QR code posted right there on the slide or use the URL posted in the chat box. Thank you very much for all our attendees.